Welcome to Medscape. I'm Dr. Andrew Wilner, and I'm here today with Dr. Karine Abou Khaled. Dr. Khaled recently presented her research at the American Epilepsy Society. The abstract was titled, Utility of a Simplified 15-Minute EEG Compared to Standard Continuous EEG in Critically Ill Patients. Welcome, Dr. Abou Khaled.
Hi, thank you for hosting me.
Yeah, thanks for joining us. And I'm really glad we have this opportunity because this is a question that's been bothering me about the application of resources, because a 15-minute EEG takes about an hour for our techs to do, and a 24-hour EEG takes 24 hours for them to do, plus a lot longer to interpret. So I think it's a very important question. But first of all, Why would you do an EEG at all in critically ill patients? Why is this even an issue?
As neurologists, we're always haunted by missing subclinical seizures and having all these small events we can't really see and diagnose clinically. For years, people really investigated the continuous EEG and considered it as a gold standard to diagnose subclinical seizures and, of course, to investigate why some patients are still comatose and not improving in the ICU. In some countries, such as Lebanon or even other countries or hospitals, where you don't have available techs all the time, when you have financial issues for coverage, when you have even sometimes interferences in the room and noise, and all these artifacts that you could see with regular EEG and applying cup electrodes. So you wonder whether you could have an alternative technique that could be useful. And what happened is at the hospital where I practice in Lebanon, it was a routine to do a subdermal EEG for 15 minutes because we don't have enough techs. They don't have enough time, and when they tried to use the cup electrodes, they had a lot of artifacts, noise, interferences from the room. So basically, we had better impedances and better results using the subdermal electrodes, and this is how it started. And we published a couple of years ago an article in Clinical Neurophysiology Practice that looked at the rapid response EEG with needle electrodes in our intensive care units. And our results were actually not so far from what you really see in the literature in this kind of patient population. And we had a study on 123 patients. So once we had this data, we wondered, well, if that same patient who had a 15-minute EEG and had such a finding, let's say diffuse slowing or PLEDs or GPDs or whatever, what could you see on an extended standard continuous EEG? I applied for a grant from the St. Joseph University of Beirut, and we performed the study I just published at the American Epilepsy Society meeting. We took 30 patients. We had a 15-minute EEG done, which was the fast, simplified EEG using subdermal electrodes. And then right after that, so we took out the subdermal electrodes and we did a regular standard continuous EEG on these patients. And we compared the data we found using the 15 minutes compared to the continuous EEG.
Before we get to the comparison, I guess you've raised another issue, which is subdural versus the standard electrodes that are glued on. Does that produce a difference in sensitivity and specificity?
Well, we didn't really look at the electrodes per se. We looked at whatever we could collect as data from the EEG. But we definitely have better impedances. Before we moved our ICU, we had actually even the MRI 3 Tesla machine on the floor right below us. So the older tech we have would tell me, oh, doctor, it's not going to work. because she really was resistant to use the cup electrodes because it was much easier for her to get a good signal on the EEG using the subdermal. If you consider door to door, let's say when you call for an EEG and have the EEG machine transported to the ICU, insert. So how much time does it take to prepare with a meal prep or whatever and put the gel and glue the, the cup electrodes? The subdermal are so easy. Less than a second and you have the EEG inserted. And it's not only a subdermal EEG we use a simplified montage. That means we only use the frontopolar, frontal, temporal, and occipital electrodes. So we're not doing the full 21 electrodes headset. We use a simplified montage, and this is what we compared. Simplified subdermal versus full head EEG cup electrodes.
If anything, the 15-minute EEG is really starting with a little bit of a handicap because they have fewer electrodes. So, all right, so compared to 24 hours, the question is, how much did you miss with 15 minutes versus recording overnight?
We missed extremely rare abnormalities. So out of the 30 patients, we divided them in 15 patients who had almost normal, like mild diffuse slowing at background, versus patients who had focal or epileptiform abnormalities. We had only one patient who did not have any epileptiform discharge on the simplified EEG and who was found to have abnormalities on the continuous 18 hours average. And then the two other patients were actually patients who had abnormalities, but the intensivist decided to put the patient in burst suppression. It's going to be tough to really say how much we could miss, but if I can give you numbers overall, we had 43% of the patients who had mild diffuse slowing at baseline. So among them, one developed epileptiform discharge on the extended continuous EEG, and the two others had burst suppression. So the negative predictive value was 0.77. And the sensitivity of the simplified EEG overall was 83% to detect epileptiform abnormalities. And we even did a comparison. We had a good level of agreement between the two tests. We did the Cohen kappa, and it was 0.76.
Okay, so did you miss any subclinical seizures?
Full head. Apparently, we could say that we did not miss a subclinical seizures. So let's put it this way. All the patients who had seizures on the continuous EEG had seizures on the simplified EEG.
So, because that's what it's all about, right? You're concerned about the prognosis and the appropriate treatment of the patient. And there's no question if you do 24 hours or 48 hours or 72 hours, you're going to pick up more subtle things. The question is, does any of that make any difference in the patient outcome? What do you think?
We looked at the outcome, and there was no difference regarding the outcome. So overall, there was no significant relationship between any of the EEG results and outcome. We classified patients' outcome according to the Glasgow scale, so 0 to 5, and there was no difference. And actually, we are in the process of preparing the manuscript, and we're going to publish all this data in details.
One detail is, what was the etiology of the coma in your 30 patients?
We had 17% who had anoxic brain injury, 57% who had acute brain injury, strokes, acute hemorrhage, traumatic brain injury, and the rest, around 27%, had toximetabolic infectious etiology.
Your conclusion, just to reiterate a little bit, is that the 15-minute EEG that you did pretty much resembled the 24-hour EEG.
Mhm.
And in no case did you miss anything treatable that would have changed the treatment.
Exactly. Exactly.
All right. Well, what did Dr. Hirsch think about that?
As I was telling you, Larry Hirsch was actually my mentor. I did all my researches with him on continuous EEG and all this data. And he's the one who actually pushed me to do a formal study comparing the simplified to the continuous. So here, really, I would like to thank him because initially the first impression I had when I came from the United States and started working in Beirut, initially I was shocked and I thought, well, oh, this is bad. I cannot tell people that we really do such a thing. I tried to convince the techs to, sometimes they would do a full head EEG or an extended EEG just to please me because I'm sometimes OCD about not missing a seizure. But at the end, our techs were right. They had good experience, and the technique they were using proved to be feasible, easy. But most importantly, the subdermal needles, because people can be scared to use subdermal, especially I'm talking ICU patients who could have liver issues, who are anticoagulated. Some of them had a high INR. So you would think, oh, this is invasive, you're gonna do harm. But at the end, none of our patients had any issue. We were doing a short study. But I can tell you, in a lot of patients, we have kept the subdermal 8 needle electrodes for 24 hours or even more for days without any issue, especially on weekends or when the tech couldn't come, because this technique is easy enough to be applied by a nurse or a resident, so I don't have to actually bring the technician.
All right. Well, I think your study is very important and is provocative.
I would like to thank the team, the residents, the technician. Especially the past year, we've had the war, we've had a lot of stress. Despite that, we are still doing research and encouraging our students to pursue this.
Dr. Karine Abou Khaled, thanks for joining me on Medscape.
Thank you. Thank you.
I'm Dr. Andrew Wilner. See you next time.